You know what? This
Hmm.
session is being recorded. Okay.
Perfect. All right. Well, we can pick up a little bit where we left off last night, talking about preoperative evaluation. This time, going a little further in depth into some of the outcomes and talk about not just helping patients to survive their perioperative experience, but actually recover in a better manner. So we talked yesterday about cardiovascular outcomes, postoperative major adverse cardiac events, also called MACE, as a leading cause of mortality. It's a large public health problem in the world. And unfortunately, there really are not that many interventions we know that are effective in improving outcomes at this point in time. Today, we'll focus on other outcomes that are contributory to not just morbidity and mortality, but also to other sort of softer outcomes like the length of stay in the hospital and the patient's return to a quality existence, quality of life. We'll focus a little bit on a few organ systems, pulmonary system, neurologic, and hematologic. We'll talk about some issues of functional recovery, so-called, and we will talk a little bit about evaluating preoperative laboratory testing and certain nuances of this testing, whether we should be sort of moving in a direction changing our practice. And then finally, we'll talk a little bit about so-called care pathways, which have become very popular in the United States, and value and standardization of care. So let's first talk about preoperative evaluation and testing. Again, the questions that we want to ask ourselves are, how often do an abnormal findings and test change the perioperative management? Second, how often are these changes in management actually going to be beneficial to the patient? And are there better risk assessment tools out there than the ones that we are currently using? So where should we really be focusing our efforts on this, and who's at risk of dying or having being disabled as a result of the operative experience? I think we can look at the big picture. Annually, millions of patients die in the world within 30 days of elective surgery. And as an example, we talked last night about this POISE cohort of patients who had almost 6% of them had heart attacks within 30 days of surgery, and over 10% of those heart attacks were actually fatal. And 3% died, and 0.5% of them had a stroke. And we talked also about what were the characteristics of these patients, because this is a very high rate of problems. Secondly, so we talked about the revised cardiac risk index score, where patients had to fulfill at least one of the 5 criteria, meaning presence of coronary disease, history of heart failure, history of diabetes, history of renal insufficiency, or cerebrovascular disease. So one of those 5, and then had to be undergoing at least moderately high-risk surgery. So we'll talk a little bit about how this risk scale was actually developed, and secondly, how we can make it useful, and where it sort of falls short, how we could actually come up with something better. And we'll talk about newer assessment tools that may improve prognostic information that is derived from this RCRI, and possibly give us alternative but possibly more useful information. So taking a step back, really, in fairness, what is good about the RCRI, and why did it sort of catch on, and how is it useful? For one thing, it's got a simplicity that it lends itself to algorithms for workup. So it categorizes people, low, medium, high risk, and this helps when you need to make a binary decision, a yes or a no. It's a lot easier to sort of hang your hat on that, so to speak, or sort of to think about it in those terms. The clinical risk factors we talk about are unambiguous. So you're either diabetic or you're not diabetic. You have kidney failure or you don't. And they're sort of, for the purpose of the scale, they're equally weighted. So nobody has to do complicated arithmetic to use the scale. the scale provides some decision support for triage of a workup, and it's actually simple enough that you don't have to be a physician to understand it. For example, at my own institution, I run the pre-op clinic for the cancer center, and we often have to decide. We have lots and lots of patients. We see about 25,000 patients in clinic every year, but we have to prioritize who's going to get seen earliest and first. Unfortunately, there's not a physician doing this triaging process. It's a clerk. And so the clerks need an easy way to understand who's complicated and who isn't. So these kinds of scales are very helpful when the clerk can say to the patient, ask the patient 5 questions, and on the basis of those 5 questions say, you've got to get an early appointment. So it's a very useful scale in that way. And when we do send patients to get further workup, we can sort of do so having an understanding of what the probability is that the patient actually has the disease we're looking at. So it reflects prevalence of disease. So it's actually a very helpful scale in that manner. So if we look at various types of surgery here on the bottom here, and this is AAA, repair, other vascular surgery, thoracic, abdominal surgery, orthopedic, and other. And this is the percent of patients who had postoperative major adverse cardiac events. And this was the study upon which the RCRI was derived by Lee and colleagues in 1999. And you can see that here that as you have 1, 2, 3, or 4 of these points, your risk of major cardiac events does indeed increase. You can see with vascular surgery, it's not quite as neat and clean, and that's one of the criticisms of this scale, is that for vascular surgery, RCRI is not perfect. But you do see this pattern where the more points you've got, the greater the probability that you're going to have a postoperative adverse cardiac event. What does this mean here? The ROC is equal to 0.774. What on earth does that mean? So what that means, it refers to the trade-off that exists in any kind of test between either having too much, having too fine a net, in other words, to have a test be too sensitive and incorrectly call disease present where it isn't, versus have the test be very picky and set the bar very high and only recognize disease in very special circumstances. So every time you make a test, you're essentially living with some kind of a trade-off in that respect. Here's an example, and I won't make this really long, but let's suppose we want to decide what's the best laboratory method of deciding whether a patient is hypothyroid. So some people would say, let's figure out whether T4 is good at predicting clinical hypothyroidism. So over here we have some ranges of values of T4 from less than 5 to greater than 9. And over here we have the clinical truth. Here are these patients who are clinically hypothyroid, and here are patients who are clinically euthyroid. And you can see that as the numbers, as the T4 value gets larger, the proportion of patients who are euthyroid will increase. But you've got to decide at some point where you're going to draw the line and call somebody hypothyroid. So we can say that if let's say, for example, we're going to use the number 5 as the lower limit of normal. So we can see if we do that we'll draw a line here, and 18% of patients will be recognized as truly positive. 1 will be falsely positive, this guy. For the 14 here who are actually hypothyroid but have a larger T4 number are going to be falsely negative, and these 92 will be truly negative. So we can see the sensitivity of the test, if we draw the line there, is going to be relatively low, 0.56, but it's very specific. So we're really 0.99% specificity. Now, if we go ahead and change the cut point, let's make it 7. Now we can see that you're going to pick up more disease, but you're going to actually, some of your positive findings are going to be a little more meaningless. And if we set the bar higher to 9, you can again see that now we're getting pretty sensitive, but the specificity is going down. So as you can see, there's sort of a trade-off between one versus the other. So again, without getting too in depth into this, I think we get the idea that depending on the cut point, where you decide somebody's going to be abnormal, you're going to change your sensitivity. You're going to increase the sensitivity as you make the cut point higher, but you're going to make the scale less specific. Now, what I've done here is I've taken the inverse of specificity, and I'll show you in a minute why that's important. This reflects true negatives. So these are true positives, and these are true negatives. Now, what you'll see is that this ROC curve is a receiver operating characteristic curve, and what it actually does is that it looks at true positive versus false positive rates. And as you can see on this scale, these are the numbers for T4. As you change your cut point, you're gonna change the place on this curve.
Rachel,
Yes.
can you just define a ROC curve, the term ROC,
yes,
exactly for the folks, because I don't think they've heard that before.
Yeah, I understand. So ROC curve is a way of showing whether whether a particular test is good at picking out disease, and it will and it also will show you the point along the scale where you have the best cut point, in other words. So if you take a tangent from any point along the line, it gives you the likelihood ratio of having disease if you have a positive test. So I'll go along this in a minute. If you consider this red line to be essentially a slope of 1, that would reflect a test that's absolutely worthless. So that's going to be an area under the curve of 0.5 is tantamount to a random guess. Now, an area under the curve here for T4 is 0.86. And what that means is that T4 is pretty good at determining whether patients in fact do have hypothyroidism. So the curve shape and the position really are reflective of the quality of the test. So this is a test that's pretty good. So if you look at this is just some drawings of hypothetical ROC curves. Again, this dark line is showing you essentially a worthless test where, regardless of the value that you get on the test, it's not going to make you any more or less likely to have a disease. Whereas this, you can see the purple line is a pretty good test. This is going to be about an 80% area under the curve here. And then the yellow line is an excellent test, which is about a 90%. The closer your curve is to this upper left-hand corner, the better performer it is, the better your sensitivity and specificity, because that's really what you want. You want a test that has really both. If you're below this, then it's not just a worthless test. It's actually probably, it's giving you contrary information. So essentially, to make a long story short, this is essentially giving you an idea that the area under the curve for the RCRI was 0.774. So it's fair. It's fairly good. It's not great. It's not excellent. It's not even good. It's okay. So put in those terms, I think we have to say maybe we need to come up with something a little bit better. It's not quite as great as one would hope. So one of the problems was that this RCRI model was based on a very small number of patients, really, when we consider the diversity of patients in the world. So about 5,000 patients. So it's ROC C statistic, that's that number, indicates that it's really an okay test, but it's not excellent in its performance. its predictive value is not good for vascular surgery for whatever reason. And it doesn't also give you an idea of who is or isn't sort of in good shape for surgery. It doesn't give you a qualitative sort of indication. We'll talk about what might. So one thing that's changed over the last 10 years, as everybody knows, is the advent of this big data, where we look at big data sets, we collect a lot of information. Certainly, especially in the United States, it's become very popular. Insurers, the government, everybody wants to collect lots and lots of information on patients for a number of reasons. But one thing that's come from this is that there are a lot of big data sets, and this permits retrospective observational studies to be conducted. Now, why would we be doing a lot of retrospective observational studies instead of saying, hey, let's do an experiment, and I'm going to take the next 1,000 patients I'm going to have, and I'm going to, randomize them to drug X or drug Y? One reason we do that less is it's really expensive to do this. Whereas if you just have a big data set and you run the numbers, it's really not expensive at all. But you can also look at a lot of people, and you can eliminate a lot of sort of biases this way. So it permits a retrospective observational study to be conducted. One of these organizations collecting information is called the NSQIP, stands for National Surgery Improvement Project in the United States. So outcomes are actually measured according to certain billing codes or billing diagnoses. So the accuracy of the information may not be quite up to standards of a randomized study, but it's pretty good. But there are several advantages and disadvantages to this kind of information. Well, one of the advantages is that we can, rather than looking at 5,000 patients, we can look at many hundreds of thousands of patients and get a much better discriminative model. So one of these models is actually available for free online, and I will, you can bookmark this website. It's called the surgicalriskcalculator.com. And what this is, it's a regression model from over 200,000 non-cardiac surgery patients from the 2007 NSQIP database. And what it did was incorporate both procedural and patient comorbidity data and outcome data. And the C statistic on this is higher. It's 0.874, so it's very good compared to the RCRI alone for predicting postoperative adverse events. And the nice part about it is it's actually free to use, and it's actually kind of fun to use. Here's an example. They'll ask you, estimate the risk of perioperative myocardial infarction or cardiac arrest on a patient. So they ask you to put in his age, so he's 70. What's his creatinine? And they give you certain ranges. And this person's creatinine is greater than or equal to 1.5 milligrams per deciliter or 133 micromoles per liter. What's his ASA status? We'll call him a 3. And preoperative function, what does this mean? This means, does he live independently? Does he need some help with his, with his daily activities? And we'll say he's completely independent. And he's going to be getting aortic surgery. And so what do? You submit, and this gives you a perioperative cardiac risk index, estimated risk of perioperative myocardial infarction in this particular guy is 2.72%. And the fit on this model is pretty good. So this is helpful in that it can help you, if you're a surgeon, talk to a patient about, and a patient's family about, what is my loved one's risk of having a heart attack, and it can help you decide, wow, this is really not a trivial risk. Maybe we should send the patient to a cardiologist prior to the surgery, assuming that we have the time to do so. Maybe I should really wait to get the echo on this patient. Maybe et cetera. It may help you make a decision this way. Another tool for cardiovascular assessment that's becoming, I think, much more popular now are biomarkers. One is this brain natriuretic peptide, and what that is, it's a hormone that's secreted in response to stretch of the myocardial cells, particularly the atrium. And preoperative elevation of this marker within certain thresholds is an independent predictor of 30-day mortality in both vascular surgery patients and overall non-cardiac surgery patients. And the values here really improve the predictive performance of the RCRI as well. Now, these are preoperative values. It turns out that postoperative elevation of these markers also improves prediction of events occurring within 30 to 180 days of surgery. So this would be something where if you are caring for a patient in the postoperative period and you see a natriuretic peptide level is quite high, you might consider a more intensive sort of recovery scenario for them. Maybe they should have telemetry or be in a monitored unit or be cared for a little more aggressively, seeing a consultant, etc. Now, what about troponin values? I don't think we really have thought about using these routinely in the perioperative period, but our thinking here may change with what we're finding in new studies. We see that an elevated troponin T within the first 3 days of non-cardiac surgery strongly predicts 30-day mortality. Now, these are people who are having elevations without necessarily any symptoms at all. And this is a result of, again, a very large observational trial. And we're talking about almost an 8 or 9-fold increase in risk. So it's very, very powerful predictor, actually. It has a hazard ratio of 3.87, population attributable risk 34%. Said another way, it just means that this is very predictive of problems. In this large observational trial, only 16% of patients who wound up having some kind of myocardial event actually had symptoms of ischemia. So it actually allows people to pick up a lot of sort of smoldering problems before they become clinically evident, and really deal with them and mitigate the problem before it becomes evident and sort of it's too late, or things have now become such an issue that you can't do as much about it. So clinical use after high-risk surgery may identify patients needing referral and closer monitoring. So this is going to change our practice quite a bit, and it's really a fairly inexpensive and simple thing, again, that we can do. So what about the risk of postoperative respiratory failure? And this is something that's we don't think about enough. I think we focus a lot on cardiovascular outcomes, but postoperative respiratory failure is really an expensive and life-threatening problem, particularly as patients are older. Here again, we can use our risk calculator, because the risk calculator calculates all kinds of risks. And here are the questions it asks for estimation of postoperative respiratory failure. Is the case an emergency? So we'll make up a patient again, and we'll say that the answer to that is no. They ask the ASA class. We'll give this patient a 3. How is his preoperative function? We'll say that this person is partially functionally dependent. It asks, what kind of procedure are we going to give? Now, this is somebody who's going to be getting, let's say, a gastrectomy or a Whipple, a pancreatectomy. And it asks whether the patient has any kind of inflammatory problem. We'll say, yes, this patient actually has systemic inflammatory response syndrome. So that'll mean an elevated white count and a fever or some kind of combination of symptoms like that. So putting all that together, this is actually staggering. His risk of postoperative respiratory failure is almost 1 in 4. It's very high. This is very helpful in planning a patient's surgical venue. Certainly, you wouldn't operate on this patient in a place that didn't have an ICU that could take care of him afterwards, or put him, leave him ventilated for a period of time, etc. So this may also help with an elderly, frail person with decision making about whether the months left of life are going to be spent this way. So I think that this risk calculator is very useful. Now, if we want to talk about just preoperative testing in general, I think one thing that's changed in the last several years in the United States is there's really been a move away from routine laboratory, and there are several reasons for that. And I'll talk at first about one of them, and that is what's really a normal test result. If we test somebody and we say, your potassium is 3.5, oh, that's low. Or if you say your hemoglobin is 9.6, that's low. Where do we get these? Where do we get these cut points? And for many laboratory tests, this normal value is actually based on the results of a pool of samples of large populations of patients. And when we have a sort of normal distribution, which is another term which means that the distribution of values falls along a bell-shaped curve, we define the abnormals as being the 2.5% tail on each side, meaning 2 standard deviations. And so anybody who lives on one of these ends of the bell is considered abnormal. Now, these are, in this case, normal that is non-diseased individual who just happen to be on the edge. So you got to define it somehow. 5% of normal individuals in any population will have a result outside of the normal range. So what does this mean? Let's state it another way. 5% of results in patients without disease fall outside of the normal reference range. So if we order 2 tests on a healthy individual, the chance of both tests being normal is 95% times 95%. So it's just 90%. And again, stated a different way, that means that there's a 10% probability that at least one result, not the patient, the result, will be abnormal. Now, if we order 10 tests, there's going to be a 40% probability that at least one of the results will be abnormal, whereas the patient is fine. So basic metabolic panels consist of 7 or 8 tests. You can see where we're going. We're going to get a lot of abnormal values and not really know what to do with them. So here's an example. Per an anesthesia protocol in the United States, this was recent, a 64-year-old scheduled for hernia repair would need a CBC and what we call a Chem7. So you get the results back. He's got a hemoglobin of 11, a hematocrit of 33.7, a creatinine of 1.2. So are we good to go? Do we need anything more to be done? Well, here's the problem. If you, per an anesthesia protocol, ordered these tests, the question is, who's going to go talk to the patient and say, hey, you have anemia and you have renal insufficiency. Maybe you should go get a colonoscopy. And while you're at it, maybe we should do an abdominal CT to rule out renal cell cancer because we've got this creatinine that's abnormal. So, and then you're going to have to make sure the patient goes and follow-ups with his primary doctor, his nephrologist, etc. Actually, studies show that a vast majority, at least in our country, a vast majority of abnormal results are ignored and don't impact the anesthetic plans. Now, if you lived in an ideal world, we probably would send these patients to get all these things done. But when we're doing this preoperatively, we're very focused on something. And so getting these lab results is not going to help us change the care of the patient. So the ASA, the American Society of Anesthesiologists Task Force, came up with a consensus statement in 2012 saying essentially preoperative tests should not be ordered routinely, but when they are ordered, they may be ordered on a selective basis for purposes of guiding or optimizing the perioperative management. So in other words, if a patient comes to us getting a hernia repair and we don't have a hemoglobin, we should ask ourselves, do we need a hemoglobin for a hernia repair? And it actually turns out we're spending a lot of money getting tests on people where it's not going to change the management at all. So this is a guideline now that we're not supposed to be testing people for these things. So rarely do we really document why these things are going to be ordered. So let's talk about several lab tests individually. One is the hemoglobin. Overall prevalence of anemia in 8 studies put together was about 1.8%, higher, not surprisingly, in older patients. But one of our colleagues at UCSF, Sam Rozanek, did a large study, showed that the prevalence is of anemia is high. It's actually 10% in his study of patients over 70 years old. But baseline hemoglobin has been shown to predict the need for transfusion associated with a significant blood loss case. So if you are going to go into surgery and you know you're going to do multiple levels of spine fusion, or somebody's going to have a redo hip replacement, getting a baseline hemoglobin does make sense, because there's a good chance that that patient's going to have a large blood loss, and there's a reason for the hemoglobin. If you're going to get a hernia repair, I don't think so. Zanuck, from this study, concluded that although more prevalent abnormal hemoglobin values were not actually predictive of adverse outcomes, surprisingly, in all comers. So the bottom line here is we need to be selective and not worry about getting these tests on everybody, but think about the clinical scenario, and certain operations, absolutely yes, we should get them, but we shouldn't feel that we're missing something if we don't do it on it every time. So routine hematocrit or hemoglobin is not indicated. Clinical characteristics to consider as indications for such tests include the type and invasiveness of procedure, history of anemia, history of bleeding, and other hematologic disorders. So what about coagulation? So the PT and PTT were developed to evaluate patients with either bleeding diathesis or to monitor anticoagulation. It turns out it also has been useful in the MELD score to assess the severity of liver disease. But these were never intended to be screening tests for unsuspected disorders of hemostasis. So the PT, the prevalence of an abnormal PT is less than 1% of patients in 5 studies. Both normal and abnormal results are poor predictors of bleeding risk. So if you're normal, it shouldn't be reassuring. If it's abnormal, it's really not all that indicative that you're going to have a problem. 25 studies of PT in patients undergoing a spectrum of invasive procedures showed that 1.3% of these patients had an abnormal PT, had major bleeding. 4.8% of patients with normal PTs had major bleeding. So it's really that's really not helping you very much. The PTT, the prevalence of abnormal PTT is higher. It's as high as 6.5%. But again, it's actually not predictive of bleeding if looking at all comers. So it's not a good test to just get as a fishing expedition, as, hey, let's just make sure, we want to be careful. Let's make sure the patient's not going to bleed. Let's get a PT and PTT. It turns out that these are not helpful. What is helpful is asking the patient about bleeding, taking a very careful bleeding history, and considering the surgery. So routine coagulation testing to predict bleeding risk in unselected patients prior to surgery is not recommended. A bleeding history, including family history, evidence of excessive post-traumatic or post-surgical bleeding, and use of antithrombotic drugs should be taken in all patients prior to surgery. So this is, it takes more time to ask these questions, but it's a lot more predictive, and it's actually free of charge. So if the bleeding history is negative, no further coagulation testing is needed. It's different if a patient's on anticoagulation therapy. That's a completely different story. Now, what about electrolyte testing? We love to do this in the United States. Lots and lots of labs make lots of money testing, average patients' sodiums and potassiums. The prevalence of abnormality was 12.7% in 8 studies, so it's not a small thing, but most abnormalities could have been predicted on clinical grounds. For example, patients who are on diuretic therapy or who have renal disease. And those patients, if we test them, we're not doing routine testing, we're actually doing sort of directed testing. We're picking out patients and saying, you're on a diuretic, I'll test you. That's a different story. We want to, that's a rational decision. But even when we find abnormalities, really only 1.8 of the time do these tests affect management. And here is an example, and that is hypokalemia. I remember that back in years prior, that cases would be actually postponed or canceled for hypokalemia. It turns out that hypokalemia does not appear to be a risk factor for adverse perioperative events unless the value is really low. And so mild hypokalemia just doesn't seem to be a clinical issue in patients generally. So it's not something that we should be worrying about unless we have a real clinical suspicion for it. So the ASA says clinical characteristics to consider before ordering pre-anesthesia serum chemistries include likely perioperative therapies, endocrine disorders, etc. So what about renal function? Renal insufficiency is an important risk factor for postoperative complications. In fact, we know the serum creatinine of greater than 2 is one of the 6 risk factors for major postoperative complications. The prevalence of an abnormal BUN and creatinine was 8%. In fact, 12% of patients over 70 in Xanax study had some renal insufficiency, but only 2.6 of these abnormal tests actually impacted management. So again, I think certainly in young healthies, asymptomatic patients getting renal labs makes absolutely no sense. If you're an elderly patient, okay, you have a little higher prevalence, it might make sense. And certainly if it's going to impact your care, if you have higher risk surgery, etc., where you may anticipate a lot of fluid shifts, again, now we're talking about something different. So they recommended that order these in patients only with known renal insufficiency, diabetes, hypertension, known cardiac disease, treated with nonsteroidals or ACE inhibitors, or undergoing major surgery. What about glucose? Diabetes requiring insulin is identified as one of 6 risk factors for postoperative complications. Prevalence of abnormal glucose results was 9% in Xanax study. Most occurred in known diabetics. Only 0.5% affected management. So that's corresponds with less than 1% prevalence of unsuspected diabetes. Most of these were clinically insignificant and ignored. So we actually have had some issues in the last couple of years in our pre-op clinic where glucose was ordered on non-diabetics and the insurance company refused to pay. Patients got very upset. It turns out the institution had to reimburse the patients. So I think that it was a little bit of a bullying maneuver on the part of the insurer, but really I think they're right in the sense that this is not an indicated test. So only ordered glucoses in patients with diabetes or symptoms suggesting diabetes. Now in a diabetic, I think what's much more useful is the hemoglobin A1C, which actually has been correlated with glycemic control, and elevated values seem to be associated with adverse outcomes. So I think ordering hemoglobin A1Cs in preoperative patients, especially for more complicated surgeries, is actually indicated and is a good idea. In patients with A1Cs of 8 or higher, if you can postpone surgery, particularly an elective case like a hip replacement or a knee replacement where the consequences of infection are dire, I think that's actually something that makes sense and is reasonable. Urinalysis, prevalence of UA abnormalities, almost 20%. They're poor predictors of adverse events, and they rarely change management. So the bottom line is that urinalysis should be only done in selective cases where there's suspected to be a problem.
Rachel, can I interject?
Yes.
Urinalysis, urinalysis for older women having prosthetic implants of any type, such as total hips, total knees, whatever, anything that's going to be implanted, even a pacemaker.
I think that's different, and I don't think that's routine testing. I think that's very directed. So I think maybe some of this is subject to interpretation, but I think your point is a good one. I think that when you're implanting foreign bodies, all bets are off, and I think routine UAs for those kind of cases, you could make a reasonable argument.
All bets are off, شباب. All bets.
Oh, sorry.
معناها all bets are off معناها معناها هي حالة خاصة، يعني الرهانات غير مقبولة في هذه الحالات. لو عندك فيميل وكبيرة في السن، شايف، وبالذات لو نصحانة وهيك، وهتزرع إشي فيها، أهم شيء هتزرع فيها بروستيسيس. urinalysis مهم. Hey, Rachel, glance at the chat box. Okay.
Oh, I have to hang on. I have to see the chat. Where's the chat box?
It's right. Click chat.
I can't see, for some reason I can't see the chat box.
No, it says chat on the right. See these blue horizontal?
Oh, now I see it. Okay, I see the chat box. Slow the speech. Yes,
Okay.
yes. Okay.
Okay.
Now I see the chat box. Okay. So let me go ahead a little bit to this. So in reality, we asked ourselves who actually gets sent to outside consultants before low risk surgery. This doesn't sound like it would make a whole lot of sense to do this, but one of the surgical procedures that's undergone the most study in the world is cataract surgery, because we do so much of it. It's very low risk for postoperative adverse events. There's really they've done large studies and shown that there's no difference in outcome in cataract surgery patients on the basis of routine testing, EKGs, CBCs, electrolytes. Personal story: when I was a resident, I was asked to do a pre-op workup on the chairman of the Department of Medicine, who was going in for cataract surgery. I was told that he needed to get an EKG. He laughed at me. I had to do it anyway. I think now the truth is that we've come full circle and we have a better understanding that doing this makes no sense for cataract surgery. The estimated monetary cost in the US of routine testing prior to cataract surgery is in excess of $150 million annually. This is very expensive. And really, have we been paying attention to these studies? This is based on a study in 2000 from the New England Journal of Medicine. So we've known this, or we should have known this for the last 15 years, that really testing before cataract surgery is a waste of time and money. Now, the problem is, if we look at the trends by calendar year here of who's the probability of being sent for preoperative consultation in preparation for cataract surgery, we can see that the rates here back in the 90s were around 10%. Well, the SHINE study came out in 2000. What's happened? We've actually sent more and more patients to get more workup in the ensuing years. So it's as if we're not really paying attention to the literature, and we're just practicing based on sort of habit and practice pattern, and not on the basis of good thinking. Now, what's also interesting is if we look at who gets sent for workup, and this includes cardiac workup, before cataract surgery, we see that it's very dependent on where you're practicing. It's not dependent on how sick is this patient. So you can see, depending on these 306 hospital referral regions, the rate of getting consultation goes from single digits all the way up to over half the patients are getting sent. So we know that these are not necessarily being sent for good medical reasons. There's a lot of economic sort of enticement to doing this. So if we look at prioritizing the quality improvement efforts, I think if we look at broadly defined outcomes, we can look at all of the patients who went through this American College of Surgery NSQIP database who had general surgery procedures between 2005 and 2006. And this was a lot of people. It was 129,000. 36 procedures were categorized according to what we call a CPT code. So there are various categories of surgery defined, and each procedure was examined for its contribution to overall adverse event or mortality burden. So they looked at each type of surgery and said how many patients who had, if we look at all the patients who had adverse events, how many came from your specialty? And how many patients had what we call excess length of stay? They come in for surgery where they should stay for 2 or 3 days, and they wind up staying 2 weeks. There were a few kinds of procedures where there was a disproportionate contribution to mortality morbidity, and excess length of stay. And the areas where focus seem to be needed are on elderly patients. Patients who have elderly patients are at risk of delirium, postoperative cognitive problems, need adequate analgesia. There are problems with having them return home, return to function, return to their normal activities, avoidance of pulmonary complications. Patients who receive anticoagulation, so clarifying coagulation status prior to surgery, identifying patients who would or wouldn't benefit from bridging their anticoagulation versus stopping it, and looking at patients with suspected or known obstructive sleep apnea. So if we look at elderly first, how does age affect recovery parameters related to safety? And one is that we can look at sort of all comers when it comes to respiratory complications. We can say that 40% of perioperative deaths in patients age over 65 are actually from respiratory complications. And some reasons why this may be are that there are some structural changes that occur in the airways as patients age. The upper airway changes. There's more fat in the upper airway. Their upper airways are more prone to obstruction. The lower airways change. There's altered mechanics of the lung. There's impaired efficiency of gas exchange. There's alterations in ventilatory drive, and there's altered protective airway reflexes, all as a result of the aging process.
Rachel?
The upper airway structural change that occurs is loss of, yes.
This is a new topic about respiratory complications. Can they take a 5-minute break?
Yes, absolutely.
Okay, 5-minute break. It is now it is now 8:37. Come back at 8:42 please. الساعة
Look at my watch here.
اوكي يا اوكي راح ناخد بريك 5 دقايق. يلا شباب ورجعوا بعد 5 بالظبط.
You say 8:41, right?
42. Yeah, something like that. 5 minutes.
42.
Yeah, I'm trying to get everybody to get a concept that a minute is a minute, not not an approximation. Yeah. Hey, back where I come from, red lights are suggestions. So.
That's funny.
All right, I'm gonna turn my mic off for a second here.
Okay, sure.
Okay, it is now 8:42.
All right.
Okay, boys.
Okay.
Yeah.
All right. So changes as patients
Can we go
age,
back one slide so we start the respiratory from the beginning? There.
respiratory complications actually were caused 40% of perioperative deaths in patients over age 65. So as patients get older, the proportional cause of death related to respiratory complications actually increases. They're more and more important as patients age. Some of this is due to structural changes in the upper and lower airways, um, mechanics of the lung, sort of less efficient gas exchange, alterations in ventilatory drive, and decreases in normal protected airway reflexes all are contributory most likely to this prevalence of problems as people age. So looking at the upper airway structure that changes over time as patients age, we can see a loss of the muscle support of the pharynx and increases in fatty tissues in the lateral pharyngeal walls. What that means is there's a greater chance of upper airway obstruction. Along with that, we see a greater prevalence of obstructive sleep apnea as patients age. Structural alteration of the lower airways also confers higher risk with advanced age. The lungs become less elastic, so there's higher closing volumes, and normal resting PaO2s, as we know, decline with age. There is a decrease in thoracic compliance, so patients tend to have this rapid, shallow breathing pattern and lower tidal volumes. We can see that actually respiratory rates tend to be preserved in older patients even when they are getting respiratory depression from drugs. So relying on respiratory rates to indicate lack of over-narcotization is not a good, not a reliable measurement in patients as they age. So the loss of alveolar and pulmonary capillary surface area seems to be related to this impairment of diffusion of gas and greater dead space ventilation. This was an interesting study done at partly at my institution, looking at the effect of age on hypoxic ventilatory drive. We can see that this is down here on the x-axis. This is various levels of PaO2, and patients were actually given hypoxic gas mixtures to breathe. And along here, the y-axis, you can see the alteration in ventilation in response to breathing this hypoxic gas mixture. And you can see the blue line is going to be elderly, and the purple line are patients or volunteers in their 20s. And if you're in your 20s, you can see that as you're breathing a lower and lower PaO2, your minute ventilation is going to ramp up and up and up and up. And you can see as you get below a PaO2 of 60, like if you're going to altitude, the minute ventilation will go way up. And if you're at a PaO2 of 40, your minute ventilation acutely will be in the high 40s if you're a normal 20 to 30-year-old. Now, down here on the blue line, if you're a person in your 60s or 70s, you can see that the response to this hypoxia is blunted significantly, and that your response to asphyxiation is really fairly weak. So this is no doubt one of the problems in the postoperative period for elderly patients. Their sensitivity to depressant medications is in part related to this lack of chemosensitivity that occurs over time. So other impairments, as the chemical responsiveness is variably shown to be impaired, the central effect seems to be more important. The output to ventilatory muscles is diminished, and we know that in older patients there's a greater sensitivity to depressant effects of opioids and hypnotics. So these are patients that we really have to be careful with, and there are a number of reasons for this. If we look at people who are having issues with coagulation problems, we look at the timing of surgery and the management of anticoagulation is important in patients who have thromboembolic disease. And if we look first on the side of the venous thromboembolic events, patients are at the highest risk for embolism have recurrence rates that are as high as 15% in the first year after the event. But really, the majority of this recurrence risk is in the first month. And if we take somebody off of anticoagulation within a month of a thromboembolic event, that there's a risk of 50% of recurrence with the interruption of the anticoagulation. Warfarin just decreases the risk about fivefold down to about 8 to 10% in the first month. So that first month after a thromboembolic event, the anticoagulation is so important that if we fail to recognize the fact that a patient's had a recent event, that we are really putting them at great risk to undergo elective surgery. So the mortality risk with a recurrent DVT and PE is 5%, so it's really quite clinically significant. So most patients, we by standard want to leave them on for at least 3 months if it's clinically possible. And the recurrence rate within 2 years of a first event is 18% after 6 weeks of treatment, 9% after 6 months. So recurrence depends on several factors. One is going to be whether this was provoked by surgery, or whether it was a recurrent versus a recurrent event that was unprovoked. These are the folks who are very high risk, and we need to differentiate between the two. So what about arterial thromboembolic risk? And we can these are events that we really should worry about even more. If somebody has had a stroke or even a TIA, the recurrence risk is quite high early on after the event. So it's about 0.5% per day during the first month after an event. It doesn't matter whether you have a residual deficit or not. And the rate of death with a recurrence is 20 to 40%. And the risk of some kind of a lasting significant neurologic damage is over 50%. And keeping somebody anticoagulated during this period really reduces the risk by 1/2 to 2/3. I'm going to skip a couple of that slide, but this is a better way of looking at it. If you look at patients who have atrial fibrillation or non-atrial fibrillation and the days after a stroke, you can see that patients during the first 3 months after a stroke have a declining survival as a result of thrombotic events, and you can see that the probability of recurrence is high in the first 180 days. But if this event is related to atrial fibrillation, it's particularly problematic. So these are patients we need to recognize. We need to look at it and understand whether their TIA or stroke was related to atrial fibrillation. And if the answer is yes, that we need to understand that these are very high-risk folks and that elective surgery really shouldn't take place during the first 3 months after this kind of event unless there's a really compelling reason to do it, or we can do it without stopping the anticoagulation. Now, I'm going to just skip over some of these things because they are this and get to where I want to pick up. So we wanted to look at a group of patients who would also benefit from improvement of care the most. And going back to that, we were talking about the one end of the extreme where we were sending patients undergoing cataract surgery to get cardiovascular workups, and this is, we know, is pretty ridiculous. But on the other end of the spectrum, where could careful preoperative evaluation and better processes of care actually really help and make patients do better? And we can look at one group of patients that we look at the most, and those are patients undergoing, actually, excuse me, I got the slides out of order. This is patients undergoing colectomy surgery. And we can see that these various types of procedures were examined from the NSQIP. And this is the number of patients who had surgery during this particular year. This is 2006. What they call the adverse event rate, and this is the excess length of stay in the hospital according, per specialty. And it looks like colectomy surgery really stands out in the crowd. One is that the number, it's a very common surgery in the United States, and I imagine that's also true here. A lot of elderly patients are getting colectomies. The adverse event rate, if we combine things like, post-operative heart attacks and sepsis and heart failure, is high. It's almost 30%. And anytime patients here had an event, the excess length of stay is long. It's almost 10 days. Compared to bariatric surgery, which we think of as high risk with surgery, their adverse event rate was really quite a bit lower. And when adverse events did occur, it didn't lead to nearly as lengthy an increase in stay in the hospital. So what can we do about this? What could we do to actually improve this picture? And one thing that's been shown to help is standardizing our care. In other words, trying to identify good practices and then implementing them sort of across the board as saying, everybody's going to do this. We're going to all take care of the patients in the same way. And what we've developed is something called an ERAS program, which stands for Enhanced Recovery After Surgery. This has become very popular actually around the world. And what it really consists of, the common features of an ERAS program are really heavily emphasize preoperative counseling of the patient. So this can include things like having realistic expectations of how life is going to be in the days after surgery, encouraging patients to optimize their preoperative nutrition. And for the anesthesia care providers, it's standardization of analgesics. And in our colectomy patients, everybody's getting thoracic epidural. We're minimizing intraoperative and postoperative systemic opiates, standardizing anesthetic plans, fluid management. We are really, really emphasizing early mobilization. So patients must be up and walking within 6 hours of the recovery room. And Cochrane looked at colorectal surgery subjects and saw that ERAS programs were related to a lower risk of overall complications. It reduced the hospital length of stay to almost 3 days. Unfortunately, there was not a difference in readmission rates or mortality. But I think this is just something that over time, these may reflect themselves as well. Possible long-term impact of something else is something called prehabilitation. And what that essentially means is that rather than waiting for the patient to have surgery and then trying to get them in better shape, you actually start training the patient before surgery. What this means, though, is that you've got to implement a program like this well in advance of surgery, so more than 30 days, and it's not feasible to do this if surgery is needed on an urgent basis. What this could mean is routine, rigorous physical training programs have been suggested, but unfortunately, and not surprisingly, there's a fairly low compliance with this. And when you put people on a rigorous training program, it looks like actually some of them get worse. Probably they injure themselves trying to go to the gym and all of this. So improvement in performance increased. If you did improve, though, if you did go through one of these programs and actually get better, then you did well. It improved the probability of a full recovery at 9 weeks. One group actually looked at something called a trimodal approach, where they looked at nutrition counseling, moderate exercise, like not going overboard and doing too much exercise, but a moderate exercise program, and anxiety reduction. It looks like if you cover all of these various facets, that these show initial promise. So if we looked at this trimodal approach, where we looked at anxiety reduction, nutrition, and modest exercise, they actually did a study where they randomized people to having this trimodal approach versus a placebo, basically nothing. And here's the baseline. This is before they have a diagnosis, surgery is planned. Then this is the 6-minute 6-minute walk test in meters, how well people performed. And if the people who got trained actually had an improvement in their performance prior to surgery. Now, in the between surgery and 4 weeks after surgery, everybody, of course, everybody has a decline, and this goes for people getting in the program and people who aren't in the program. But what was different was that in the patients who got the training, that then by 8 weeks out, they're back to their preoperative baseline. In fact, they're better than they were than when they got their diagnosis. So if you can implement some kind of a prehabilitation program that works for patients, you will actually make a really beneficial impact on their functional status at 8 weeks after surgery. Whereas if you don't, if you look at these other guys, they never quite get back up to where they started. So the suggestion is that if we really try to incorporate several aspects of optimization before surgery, that patients will, if we look down the road a little farther than just the first day or two after surgery, people will get better. This allows people to go back to their families, to go back to their jobs, to live independently, whatever it is, and it will have a very large impact on society. So this is where really you can make a big impact. So this, again, going to the interventional group, the baseline got better, control group, the performance was worse than baseline, no, they didn't want to do that. Sorry. So looking ahead into the future, just to sort of recap what we talked about, we're really trying to strive towards eliminating testing prior to low-risk surgery and doing sort of routine testing on everybody. We're trying to be more selective about referral to consultation with specific questions for specific problems. This is going to involve close communication between the surgeon and the anesthesia team. Standardizing clinical assessment and management plans shows promise. Adoption of care pathways where appropriate seems to also be good, where everybody gets together and decides on, we're going to really make a big effort to do this as a team and identify better practices. Patient education, realistic expectations, and optimization seem to be very, very beneficial. These better risk assessment tools, I think we should try to all use them and get to know them, and they're becoming increasingly user-friendly, so this is the good news. And we should we're going to look more and more at long-term outcome assessment from the post-discharge period until sort of weeks to months in the future, with an emphasis on valuing the return to full function, not just sort of getting somebody out of the hospital alive. So with that, I'd like to stop and see if there are questions.